It's Dr. Suchard again, here with a short video focusing on one aspect of hematologic pharmacology. This presentation is about drugs used in treating sickle cell disease. The objectives of this presentation are that after studying this material, medical students should be able to detail the mechanisms of action of hydroxyurea in treating sickle cell disease, and to list at least 3 other therapies commonly used in patients with sickle cell disease. As you know, red blood cells in sickle cell disease can become deformed into shapes that often resemble a sickle, the handheld farming implement used to harvest grain. In this color-enhanced electron micrograph, we see several RBCs with their normal biconcave shape. There are also several deformed cells in various shapes, including this one on the left with a typical sickle or crescent-like shape. Sickle cell disease is caused by a mutation where the DNA encodes for an altered amino acid sequence in the hemoglobin beta chain. A single DNA base pair substitution changes the coding for glutamic acid instead to valine. Changing the polarity of only a single amino acid side chain, however, is enough to drastically alter hemoglobin's ability to polymerize. As long as sickle hemoglobin, or hemoglobin S, remains oxygenated, everything is fine. But when hemoglobin S is deoxygenated, there's a slight alteration in the conformation of the beta chain, which can now associate with the substituted valine residue on the beta chain from another hemoglobin S molecule. When this continues, the hemoglobin S molecules can polymerize into long filaments that conglomerate and deform the RBCs into a sickle shape. This can damage the RBC cell membranes, promoting inflammation and hemolysis, and the altered RBC shapes are less flexible, potentially obstructing the microvasculature and causing vaso-occlusive crises. This hemoglobin S polymerization that causes sickling is basically a process of protein crystallization, and crystallization can be impeded the less pure the solution is with respect to the substance that is being crystallized. In adults without sickle cell disease, 95 to 98% of the hemoglobin is hemoglobin A, made from 2 alpha chains and 2 beta chains. A few percent of the hemoglobin is hemoglobin A2, 2 alpha and 2 delta chains, and there's also some hemoglobin F, or fetal hemoglobin, composed of 2 alpha and 2 gamma chains. In patients with sickle cell disease, who are homozygous for the altered beta chain, nearly all of the hemoglobin is hemoglobin S. But there's a relatively higher amount, about 5 to 8%, of fetal hemoglobin. And if we can increase the relative amount of non-hemoglobin S variants in the red cells, we can reduce the amount of sickling going on. Hydroxyurea acts to increase the relative amount of fetal hemoglobin compared to hemoglobin S, which will reduce hemoglobin S polymerization, reduce the amount of sickling, and therefore reduce the complications of sickle cell disease. Hydroxyurea works through multiple mechanisms, but 2 of them are the most important and will be covered in more detail in upcoming slides. 1, hydroxyurea inhibits ribonucleotide reductase, and 2, a portion of the molecule is converted into nitric oxide, which activates guanylate cyclase. This figure depicts the hematopoietic changes that occur with hydroxyurea therapy. Hydroxyurea increases the number of RBC progenitor cells transcribing the gene for the gamma hemoglobin chain such that their progeny produce fetal hemoglobin. And this is the action mediated through nitric oxide stimulating guanylate cyclase. On the other side of the coin, hydroxyurea inhibits the production of the RBC progenitor cells that make hemoglobin S. This latter mechanism occurs because hydroxyurea has a cytotoxic effect by inhibiting ribonucleotide reductase. The progenitor cells for RBCs making hemoglobin S proliferate more rapidly than those producing fetal hemoglobin, so they are more selectively killed by hydroxyurea's cytotoxicity. All this results in relatively more cells producing fetal hemoglobin and fewer cells producing sickle hemoglobin. Ribonucleotide reductase converts RNA nucleotides into DNA nucleotides, making it a rate-limiting step in DNA synthesis. Ribonucleotide reductase is necessary to make the DNA nucleotides for adenine, cytosine, and guanine. RNA has uracil instead of thymine, and you'll recall that DTMP, the corresponding DNA nucleotide for thymine, is synthesized in a process involving folate and vitamin B12. Hydroxyurea inhibits ribonucleotide reductase, resulting in fewer DNA nucleotides and causing cytotoxicity for the more rapidly dividing cells. And like other cytotoxic drugs, hydroxyurea can be used as chemotherapy in the treatment of certain cancers and blood disorders, such as chronic myelogenous leukemia and polycythemia vera. Here are some micrographs showing the effects of hydroxyurea treatment in sickle cell disease. Before treatment, on the left, we see more sickled RBCs. With treatment on the right, there are fewer deformed sickled cells, and the RBCs look rounder and healthier. In 2017, the FDA approved L-glutamine in the treatment of sickle cell disease, which was the first new drug approved since hydroxyurea 20 years earlier in 1997. Part of the pathophysiology of sickle cell disease is oxidative stress to the RBCs. Glutamine promotes antioxidant effects by increasing the synthesis of NADH, NADPH, and glutathione. The only other FDA-approved therapy for sickle cell disease is stem cell transplantation, but that's not exactly a drug therapy. The pathophysiology of sickle cell disease is complex, creating several potential druggable targets. So far, we've focused mostly on blocking hemoglobin S gelation with hydroxyurea. But there's ongoing research into blocking adhesive interactions with selectin inhibitors, beta-adrenergic blockers, and other drugs. The inflammatory component might be treated with leukotriene drugs and other anti-inflammatories. The abnormal coagulation in sickle cell disease is being treated in research studies with various anticoagulant and antiplatelet drugs, and this brings us all back around to mention another drug that prevents hemoglobin S polymerization, but through a different mechanism than hydroxyurea. Vox Alatorre is an investigational agent that increases hemoglobin's affinity for oxygen, so this drug would reduce the relative amount of deoxy sickle hemoglobin available, reducing polymerization, sickling, and other downstream effects. In addition to the more specific treatments for sickle cell disease previously discussed, there are other adjunctive drug therapies that are commonly used. This table shows treatments used as prophylaxis against complications, such as empiric antibiotics against streptococcus and polyvalent strep immunizations in young children, folic acid supplementation, and some patients with sickle cell disease get iron overload from having frequent blood transfusions, which can be mitigated by iron chelation therapy. And this slide details some treatment options to use during acute illness, including the liberal use of opioid analgesics, and rapid empiric use of antibiotics for known or suspected infections. Remember that patients with sickle cell disease are functionally asplenic and are at higher risk of infection with encapsulated bacteria. And that's all for now about sickle cell pharmacotherapy. I'll be seeing you around.